The next presenter is Dr. Hema. She'll be showing a video on a skillful surgeon for an this is another artificial alien tackling retained intraocular foreign body.
This presentation showcases different methods of intraocular foreign body removal, their pros and cons, thus aiming at enlightening the audience for an effortless removal of IOFB. Our first case is a case of 36-year-old car mechanic with a vision of 612. CT scan and B scan revealed an intraocular foreign body. Anterior segment examination showed a corneal tear, sphincter injury and a traumatic cataract. The lens aspiration was done, which revealed a pre-existing large posterior capsular rent. An intraocular foreign body was seen in infratemporal quadrant with adjacent sclerosed retinal vessels. Vitreous was generally cleared all around the intraocular foreign body, and the foreign body was allowed to gently fall on the retina all on its own. A 23 gauge magnet was inserted. The intraocular foreign body was safely lifted from the surface of the retina. A magnet helps us to hold and safely lift the foreign body without a fall than using a forceps. You can see the intraocular foreign body is brought behind the pre-existing PC rent without a fall. The IOFB was removed using an iris claw holding forceps through the same pre-existing PC rent. As this was a clean case without much sign of infection, we implanted an intraocular lens. Through this case, we highlight that the magnet gives us a firm grip of intraocular foreign body without causing a fall than using a forceps. The second point is that in cases like this where there is a pre-existing large PC rent, the same rent can be used as a route for the removal of intraocular foreign body than using a pars plana route. Our second case is a case of 32-year-old male patient with a history of penetrating scleral wound repaired 1 month back. Intraocular foreign body was missed during the primary surgery. The patient presented with vitritis and repeat B scan revealed an IOFB. He had a vision of 612. Vitrectomy revealed an intraocular foreign body. As this patient had a clear lens with a small intraocular foreign body, our plan was to go through pars plana route so that the crystalline lens is not disturbed. We did it bi-manually using a magnet and a forceps with the aid of a chandelier illumination. A 19 gauge magnet used in this case serves in two ways: lifting the IOFB without a fall and aligning the IOFB on the forceps in the correct axis for its easy removal. This case highlights the importance of CT imaging in suspicious case of metallic foreign body even if B scan is normal. The bimanual method helps us in removal of IOFB through pars plana route without damaging the crystalline lens. Magnet is an excellent tool serving multiple functions in an intraocular foreign body removal. This is a case of a 64-year-old male patient with traumatic cataract and ruptured capsule following an injury at the construction site. The CT scan revealed a large intraocular foreign body. The traumatic cataract was aspirated and vitreous hemorrhage was cleared. But there was no signs of intraocular foreign body internally. We explored externally at the site of primary scleral tear repair. A thorough exploration revealed no IOFB externally also. Now we have a situation with an IOFB in the CT scan but no signs internally or externally. The pars plana region was cleared. We could see a metallic shine at the region of pars plana. We nudged the area and an intraocular foreign body was noticed. It was grasped with a three-pronged forceps and was externalized slowly in a controlled manner. At last, here comes a large intraocular foreign body. The lesson learned in this case is how the objects in the CT scan is projected more posteriorly than it actually is. We thought the IOFB was at the level of the retina and searched internally, but it was actually at the level of suprachoroidal space. Thus, it is projected more posteriorly on the retina in the CT scan. A pre-planning of IOFB removal with the aid of CT scan is highlighted in this case. The retinal detachment in this case was managed with the silicone oil infusion. All cases are not necessarily superficial or over the retina so that we can easily grasp it. They can be incarnated deep subretinally even to the suprachoroidal space. Our next case is such a case. An anteriorly located such an IOFB can be removed externally, but posterior suprachoroidal IOFB has its own challenges. The most important point is to remember is a massive suprachoroidal bleed. Here the surgeon is attaining a proper hemostasis to aid the removal of IOFB using a laser and diathermy. Also, IOFB should be removed in a controlled manner and the infusion pressure should be kept high to avoid massive choroidal bleed. Thus, these three steps, diathermy, laser and high infusion pressure, help us to avoid massive choroidal bleed in this case. Here, the surgeon is trying to remove the IOFB with a forceps. We can see that the IOFB is falling on the retina multiple times. If he had used a bimanual method, as we have discussed earlier, this could have been prevented. The take-home message in this case is the importance of a hemostasis in deep intraocular foreign body and once again highlighting the importance of bimanual method.
So last case was not yours.
Yes, ma'am.
Then why did you use that bimanual technique?
Actually, we thought it was actually a big, moderately big IOFP which can be grasped with the forceps. So we thought it can be removed. But after grasping it only, we found it was falling down. And in next 2 steps, it came out. But initially, also we wanted to highlight this can be a mistake and we should be precautious. Even for any size of IOFB, it is better to use a bimanual.
Okay, and also you haven't used that magnet also.
Yes,
last
ma'am.
case.
Bimanual with magnet and forceps.
In your third case where you found a large foreign body, did you consult the radiologist? I mean, I think you wouldn't have got a doubt, I think. You would have thought it is in the...
Yes, ma'am. Actually, we thought it is in the subretinal space, and that's why we went internally and externally. And internally also, before nudging the pars plana and clearing the base shaving, we couldn't find any suspicious lesion. I mean, points towards IOFB. Then when we were pressing and after clearing the base shaving only, we found that suspicious metallic shine. When we couldn't find internally, we thought it will be an externally.
Externally, so you started exploring outside.
Outside also.
Why did you do a B scan for that patient?
Yeah. The next question is, did you do a B scan early, before sending the patient?
B scan.
Or do you do routinely B scan?
We do routinely B scan, ma'am, but this patient already had come with the CT scan from outside, referred with the CT scan, so we directly took. But for all cases, we usually do B scan, and in suspicious cases, even if there is any sign of any corneal tear, lens cataract, or iris tear, even if the B scan is normal, we always do a CT scan, especially for medico-legal causes.
So the point is, even if you have a CT, better to do a B scan also. B scan is readily available in department, no?
But this minute difference might be missed in B scan also. The plane is better in CT scan than in B scan. We will understand which is the plane.
It is just given a linear.
Just a small shadow for such a big foreign body.
But I think it was not like horizontally placed. It was placed in like radial, not in a oblique manner. That's why in multiple cuts we are getting the shadows.
Okay, good.
Thank you.
Thank you.